dig it, down, dig it, dig it, dig down, dig it, dig down, down, dig down. Dig it, dig it, dig it, dig it, dig it down. Dig it, 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 digit, 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 Thank you.
Pure elegance. I think that's the exact word for it. Pure elegance, even with the traditional didgeridoo. Welcome to Melbourne. I'm Ian Hunter. I'm about to give you a welcome to the event here. I'm a descendant of the original inhabitants of the Melbourne region, where the coming together of you people are from all over the world actually is occurring at the moment. So yeah, Ian Hunter, is that a good name for an Indigenous person or what? You're going to be totally disappointed because the name Hunter comes from my father's side of the family, and his father, my actual grandfather, came from, hopefully maybe there might be some people out there from that same region of the world. So my grandfather came from a little place in the Highlands with the name of Inverness. Do we have any Scots out there? Yeah, welcome to Melbourne. See, I do have Indigenous heritage on my mother's side of the family. I only have to go back 4 generations to find what you might refer to as, oh yeah, that's the proper Aborigine, people do. And the thing is, going back those 4 generations, when my great-great-grand was born, there were no Europeans here in what we now know as Melbourne. So it's a very, very quick time between my great-great-grandma and today, myself. And I actually work a lot in schools, and I actually ask school children, do you have a great-grandma alive? And yes, we do. Well, I'm talking about the same what you have in your family alive today is back from me when the first Europeans came and settled where Melbourne is today. So I'm proud of my Indigenous heritage, but I'm also just as proud as my Scottish heritage. So that, to all of us Australians here, that makes me a proud Australian. I'm not a Scot originally. I'm an Australian and proud of both of it. Now, the thing is, a lot of our traditional people, of the giving of the traditional welcome to people to our country was given by eucalyptus leaves, given to the newcomers coming to our country. But I've found in recent times, unless they're an extremely impressive leaf, people leave them behind. So I'm about to give you something that you cannot leave behind. I was listening to a great aunt of mine, and this was a fair while ago that it was actually recorded because it was on reel-to-reel tapes at the Melbourne Museum when I was listening. And this great aunt of mine was asked a few questions that were relevant that I thought. And the interviewer or the anthropologist asked her, what do you refer to yourselves as? And she said, oh, we are Wungi, or you might refer to us as Kulin, meaning people. And he said, what about me? I'm not Indigenous, I don't have dark skin like you. What, do you have a word? She said, yes, we do have a word for you. You are Namuji. And then, of course, his question was, but how can you have a word for something that does not exist? And, people have to realise that Indigenous peoples of Australia have an amazing sense of humour. And I think she was throwing a bit of humour in here. And she said, well, and as a matter of fact, you did exist. When we dreamt of you, the old ancestral people, in the dream time, you've got your eyes closed and it's dark. How on earth are you going to see someone with dark skin unless they smile? And she said, our ancestors that came back to us in our dreams were white. So we refer to them as the white people of the dreaming. So we have a word for that, and the word was Namuji. Oh, okay, so that sort of fixed that part of it. Then he thought he could confuse her, and he held up a metal saw. He said, I guess you wouldn't have a word for this. And I can see her with a big grin on her face. She said, well, as a matter of fact, we had two words for that. And the words were Gigal Gumbalai. But you didn't have metal. She said, no, Gigal means go away. Gumbalai means come back later. She said, so the saw was a go away, come back. So listening to that part of the interview, I thought, there are four amazing words there for a welcoming song. Gigal Namuji, go away, white fella. Gumbalai Coolin, come back, black fella. Meaning, all the people and the traditional peoples of the world have the same ideals, meaning let's look after the people and look after the land. So the song is not negative, it's a positive song, it's a positive chant, meaning for a little while in our hearts and our minds, go away with our ideals and European idea of accumulating material items and so forth. Think about the land and think about the people, the way that the Indigenous peoples thought about one another. And that hopefully this chant will stay right in the annals of your memory, and it'll come back every now and then. So the leaves can be taken away, but this is not ephemeral. Giganamuji, 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 Gambalakulan, Gambalakulan, Giganamuji, Giganamuji, Gambalakulan, Gambalakulan, Giganamuji, Giganamuji, Gambalakulan, Gambalakulan, Giganamuji. Wominjeka, and welcome to the traditional lands of the Wurundjeri people, Wominjeka. And thanks for inviting me along to actually welcome you to our traditional lands, Wominjeka. Thanks very much. Thank you.
Thank you, Ian, for that wonderful welcome to country. And thank you all for being here. My name is Ahmed Ali, and it's my privilege and honour to welcome you here to Melbourne for IFSO 2024, our World Congress. So I've had the privilege of being the co-president in organising this Congress for everyone, and I'm delighted to welcome you here for our Congress and to this opening ceremony, and to welcome you warmly to Melbourne. Our host city is welcoming, and we really do hope that you get out and enjoy Melbourne. It is a wonderful city. So yes, enjoy the Congress, but please take some time to get out into the city and explore everything that it has to offer. Here at the Melbourne Convention Centre, we're situated beautifully. You may not have had a chance to explore just yet, but if you walk straight out these doors and keep walking straight ahead, you'll find yourself on South Wharf. Abundant cafes, plenty of entertainment. And if you turn right and walk down towards South Bank, you'll find more of that. And all you need to do to explore the city is cross the bridge over to the river, and you're right in the heart of the city. Our Congress theme this year is integration. And we've worked really hard to bring together a program that really reflects that. Yesterday we had a very successful day with our pre-Congress courses that were superbly attended. And again, I thank you all so much for making the time and attending our Congress and these pre-Congress courses. I'd note in particular the Integrated Health course and the Scope School, which were new events here, attended so well by that Integrated Health group, in fact, outdoing the surgeons. And we've put together 78 diverse sessions for our integrated program. And if you notice on the program, there is colour coding. And so what the red sessions indicate surgical type sessions, The green sessions are the dedicated integrated health sessions, but if you look broadly across that snapshot, there's a lot of yellow. And the yellow are the mixed sessions where there's interest across the whole group, integrating our knowledge and science and activities so that you can bring that integration back into your practices. The program has many attractions, and one of the new things that we're doing this year is running a plenary session on each day where we explore the big ideas and the big questions with the world experts. We've got some wonderful keynote speakers, and we'll be kicking off with that shortly. But each day has a plenary, and on the Friday, of course, we have our standard presidential session. Our 78 sessions will explore AI and technology, surgical advancement, obesity science, plenty of videos and fun to do, as well as a session on lived experience. So we really want you to get involved in the program, find what interests you, and take all of that back home with you. And of course, we have our standard IFSO fun events with the chapter championships, the bariatric quiz, there's the case conundrums to finish the Friday, and our MasterChef competition on Wednesday at lunchtime, where the best recipes in the integrated health program are going to be put to the test. So get along and see that. We had an overwhelming number of free papers submitted, 735. We were really overwhelmed by that, and our reviewers worked very hard to bring it down. We've got 345 presentations across 28 free paper sessions, including 88 integrated health. Great representation. The top paper sessions, if you're looking for those, are on the Friday. They run parallel after the presidential session. In those 28 free paper sessions, we've had to really accommodate, we wanted to accommodate as many people as possible. So you'll see there's a mixture of extended presentations at 6 minutes, and then we have the challenging rapid fire presentations where you get 3 minutes. And that timing, our moderators are Aussies, they're pretty tough. They're going to be hard on you, they're going to cut you down, but we're going to have a bit of fun with it. So at 1 minute, you'll hear that sound, and you know you've got to race through the rest of it. And once you get to the end, you'll hear this. And you'll be welcomed off the stage. Maybe not quite so violently, but yes. And we will be awarding in each of those sessions the sharpshooter prize. So the 3-minute presentation that sticks to time, gets their message across, they'll win a little Australian prize at the end. So gear up for that. That'll be good fun. We've also got breakfast sessions this year, which has not traditionally been run a lot at IFSO, but in Australia we do get up early with the birds and the kookaburras. You'll hear them sing, they'll wake you up. So come down for the breakfast sessions. Some of those are industry sessions. And if you're looking for the list of those, go to the program and you'll find under there the industry sessions listed. So we thank our industry sponsors and partners for putting on those breakfast sessions and lunchtime and dinner sessions as well to add to our Congress. And I'd like to thank as well our partnering associations that are running sessions here and indeed helped with the pre-Congress courses, the World Obesity Federation, or Gastroenterological organisation, and ISCOP. So again, look at that, that's part of our integrated themes. In the main foyer, you'll see the Australia Hub, and there'll be a lot of activity there, a lot of entertainment for you in between sessions, or some maybe if you're skipping a session, but let's not encourage that too much. There's a travel agent, so you can get some ideas how to explore Melbourne, how to get around Australia. A souvenir shop, I know you all want one of those Akubra hats. And a little bit of Aussie cuisine, nothing too fancy, but I'm sure you'll enjoy the Tim Tams at least. We'll have competitions and prizes, and we want to run a chapter championship on interpreting Aussie slang. So if you've heard some of the expressions we used and scratched your head, come along and you might get some answers. Of course, we can't get anywhere without our industry partners, and I'd really like to thank our visionary partners, J&J MedTech, for partnering with us yet again. And really, these conferences can't happen without that support, but it is a true partnership where there's integration and development on both sides. We learn from them, they learn from us, and together we go forward. Our platinum partners, Medtronic, our gold partner, Boston Scientific, and our silver partners, Eli Lilly, Gore, and Intuitive. So thank you very much again for partnering with us, as have many exhibitors in the hall, and I encourage you all to get around, visit them, find out what's the latest and how you can incorporate that to improve your practices. We also want to thank the Melbourne Convention Bureau. We acknowledge their support and that of the state government to support this event with amazing logistics assistance and some state government funding, which was really superb. And I think you'll agree the place has been set up beautifully, and we're really looking forward to an exciting Congress. Our PCO Think Business have been marvellous in helping set all of this up and developing all of the wonderful sessions with us. Now, when I began this process as the Congress President some time ago, I was young and good-looking, and now you see I'm old and grey and withered. But I wouldn't be here at all if it wasn't for these guys. Our local organising committee were absolutely spectacular in their support and in developing this. And whilst I'm standing here, these are the people really that were behind everything. As well as the IFSO Global Program Committee that gave sound advice as we developed the program on many late nights and early mornings. And of course our Queen Manuela, who just waves her magic wand whenever there's a problem and somehow things get sorted out. But most of all, I want to thank you, all of the delegates, all of the speakers, all of the participants who've travelled from far and wide around the world. It's a long way to come, and when we were planning, we thought, I wonder how many people will make this trip. We thought 1,000 would be good. We would be ecstatic with 1,500. Well, I'm so happy to say that we've had over 1,700 registrations, more than 100 each of the dietitians, physicians and nursing representation. This is the biggest integrated health presence at an IFSO meeting. And you've come from 74 countries, all over the world, all wide representation from the APC region. We've had 160 from mainland China, Hong Kong and Taiwan. 100 from the US. They made the trip out just after their holidays, so that's fantastic. And really, people have come from everywhere: Armenia, Mauritius, Mongolia, Romania, Uganda, Uzbekistan. I loved looking down the list. It was incredible. So a shout out to those guys who made that trip, and really hope you get a lot out of it. Get out to Melbourne, enjoy everything that it has to offer, and if you can get out wider to the regional areas and see the amazing wildlife and scenery, you're very welcome, and I really do hope you enjoy your stay here and have a great time. And again, I really welcome you and declare our 2024 Congress open. Thank you.
Thanks very much, Ahmed. We'll just see what turns up. Okay, I'd like to welcome you all to the 27th IFSO Congress. It was going to be 2 years ago, but because of COVID, obviously things changed. It's a pleasure that we're here in Australia for the third International Bariatric Meeting. In 1993, prior to the commencement of IFSO Foundation, we had a meeting here in Victoria, in Echuca. We had a meeting in 2006 in Sydney, and now in 2024, we are having the third International Bariatric Meeting in Australia. Firstly, let me thank my co-president Ahmed Ali, who's really worked tirelessly. He's not looking that tired today, but he has in the past, and who did most of the organisation for the Congress, particularly with his program committee of Alex Craven, Michael Talbot, Wendy Brown, Lillian Cow, Jacob Chisholm, and our PCO organiser Denise Brurian and her staff. And lastly, as Ahmed mentioned, the incomparable Manuela. Now, my greatest contribution to IFSO was Manuela. Now, the reason why, when I was president back in 2010, we were looking for a permanent secretary. And Luigi Angrisani said to me, I have this attractive, intelligent person for the job. Or did he say intelligent and attractive? No, I know, Luigi, it was definitely attractive and then intelligent. And as you know, the rest is history. Manuela has guided the IFSO from a small organisation to today over 10,000 members, 74 countries, an amazing achievement. And I'd like to thank her on behalf of everybody for that. My role here is really part of the history of bariatric surgery. The earliest operations in the mid-70s with our Australian organisation, which was originally called OSANS, the Obesity Surgical Society of Australia and New Zealand, started in 1985, 10 years before the foundation of IFSO. Andrew Jamieson was one of the founders in 85, and together with others, Paul O'Brien led the world in gastric banding and monitored the long-term results. I was president in 2010, and Lillian Cow had a huge contribution as president over a 3-year period. And as I said before, we delayed 2 years because of COVID. Wendy Brown went into a significant role in the establishment of the registries and many scientific contributions. Many others have contributed all their roles in every specialty, and I'd like to acknowledge the contribution of Ken Loy. Unfortunately, Ken Loy passed away since our last Congress in Naples. He was president-elect of, I've got here past president, but actually he was president-elect, but unfortunately died just a few days before he was due to take up the presidency. He is surely missed by all his friends in our society. I'm sure there's a glass of exceptional whiskey in his hand right now, toasting our success. So in welcoming you here to the land down under, we hope you will take the opportunity to increase your knowledge, integrate with your colleagues, meet many experts in the field, and I encourage you to engage with them. That's what they're there for. Don't be shy. Enjoy the social interactions, meet both old and new friends, and return home refreshed, inspired, and more able to provide the best possible care to your patients. Thank you. Now I'd like to invite Michael Talbot, who will chair the rest.
Welcome to the plenary. When we were designing our plenaries, we really wanted, especially for this one, a rock star vibe. And I'm pretty sure everybody in the room has the rock star vibe with how things started. We've got a great assembled host of speakers this morning. And we're living in an unprecedented time. We know with changes in data and healthcare, everything we know is going to change. But some things are going to stay the same. What's going to stay the same is us caring for our patients and us interacting with each other and learning off each other.
Right. Our next speaker is Michael Cowley. Now, Michael's coming up. Michael is the head of physiology and the School of Biomedical Science at Monash. He was the director of Obesity and Diabetes Institute, often referred to as MODI, so not to be confused with our Indian Prime Minister there. And he has spent many years in his interest in leptin in its relationship to obesity. So without anything further, I introduce Michael Cowley.
Thanks, Dr. Freudenberg. I'd like to echo Lee's thanks to Harry and Ahmed for this. It's a spectacular conference. Lee mentioned that obesity is not rocket science. I have to say, walking down those steps before, I felt like I was stepping into mission control in Houston, so maybe it is a little bit rocket sciencey. I'm going to talk to you today about the role of the pharmaceutical industry and drugs that are in development or have been developed and how they can work in integrated care. I have a couple of disclosures there. So we're going to talk about what's currently available, what's in development. I'm going to focus on something that we touched on a moment ago, specifically the growing interest in preserving function, in particular muscle, and then how combination therapy might be deployed. If you find some of the comments I make interesting, you want to dig a bit deeper, there's a spectacular review that came out recently by some of the members of this society, some who are present, published a couple of weeks ago, that I would encourage you to have a look at, because it digs into a fair bit more detail about the magnitude of the kind of weight loss we're talking about and some of the other aspects of these drugs. So we think about current obesity therapies. There are the two older drugs available in Australia that have been around for a long time. Phentermine, which is an amine, a mild stimulant, which causes, as you'd expect, a little bit of dry throat and also some arousal, and is associated with modest weight loss. Orlistat is also available and has been widely used for a long time. Orlistat's a pancreatic lipase inhibitor, so it prevents digestion of fat and so it leads to excretion of fat. These drugs have been around for a long time and haven't had a tremendous influence, as we saw from Lee, on the way we treat obesity. There are, in the late 2010s through to 2020, there was a series of new drugs approved. Phentermine topiramate is a combination of phentermine, one of the very old drugs, and topiramate, which is an atypical adjunctive anti-epileptic. And for reasons we don't really understand, topiramate causes quite impressive sub 10% weight loss, but combined with phentermine offsets the lethargy associated with some of the anti-epileptic drugs, and so is quite effective. Naltrexone plus bupropion is a drug that I was involved in the development of. And this drug also causes in that 5 to 7% weight loss range, again, quite effective. And liraglutide, a drug I think many of us paid attention to when it was first released. It was probably the most famous of the early GLP-1 analogues. It was preceded by exenatide, which was not widely used, but was very effective for diabetes. And liraglutide is an early generation GLP-1 analogue, had some influence on control of body weight. Together, these drugs all provided efficacy somewhere between 4 and 10% placebo subtracted. So in the drug development industry, we talk about total body weight loss, not the kind of weight loss that some surgeons talk about, which was the sort of idealised body weight. We talk about total body weight loss. And so the phentermine topiramate can cause up to 10% weight loss, whereas some of the very old drugs were struggling to push 4%. All of these drugs have some tolerability issues, nothing that's particularly problematic. I guess topiramate has a category X label and so shouldn't be used in women who are of childbearing age unless there's adequate precautions taken around pregnancy. But in general, they were reasonably well tolerated without dramatic side effects. Now, in the last few years, we've seen the release of two drugs, semaglutide, which is again a GLP-1 receptor analogue, a long-lasting GLP-1 receptor analogue. This drug's only taken once a week as a subcutaneous injection, as opposed to the liraglutide I spoke about a moment ago, which is a daily injection. And tirzepatide, the more recently released molecule, which is an analogue that activates both the GLP-1 receptor and the glucose inhibitory peptide, or GIP receptor. And there's considerable debate around whether a GIP agonist or a GIP antagonist is the most effective way to treat or combine with a GLP-1 analogue. And it's interesting in so much as there seems to be really quite strong data supporting both efficacy with agonism and antagonism. And as a physiologist, I say it's quite confusing to try and understand a U-shaped dose-response curve, but nonetheless, that's what we seem to be getting with GIP. And whether an agonist or antagonist is going to be the most effective drug is something that we're going to find out in the next 5 or so years, I think. But nonetheless, both these drugs have really quite profound efficacy and have revolutionised the treatment of obesity, and I think are going to have an impact on surgical practice as well. They're associated with between 12 and 18% placebo-subtracted total body weight loss, and in some trials you'll see numbers in the 24 or 25% range if you include the placebo-induced weight loss. So really quite striking weight loss. And additionally, these drugs have significant other health benefits. So in addition to their effects on glucose control, which shows up as benefits in terms of glycosylated hemoglobin changes, where you're seeing up to 2% reduction in glycosylated hemoglobin. There's excellent data around cardiovascular disease, in particular hard endpoints like MACE. We've seen some recent release around data around apnea and releases of data around preventing progression into type 2 diabetes. So not just treating weight, but treating the diseases that are caused by obesity. And so these drugs are having a dramatic impact on our practice. Now, there are clearly some issues around tolerability. Many patients can't tolerate these drugs because of the nausea and vomiting that are associated with them, or can tolerate low doses but not full dose. And more recently, the American Society of Anesthesiologists has talked about the issues associated with anaesthesia and GLP-1 analogues because of their impact on both nausea and vomiting thresholds, as well as the potential for gastroparesis to impact pre-surgical anaesthetic fasting. I don't want to dig into this. I think there's a lot of contradictory work out there. I think it's worth paying attention to, but I think there's still a lot to be done there. And as was pointed out at the ADA meeting last year, rapid induction protocols for anaesthesia are used when you don't know what the patient's been eating anyway, so it doesn't necessarily preclude surgery. I think what it does mean, though, is if you've taken a patient who's taken a long time to reach full dose of drug, is it rational to take them off drug before surgery and then have them have to retitrate all the way back up if they're a poor tolerator? I think those kind of issues are more about how we care for individual patients, but they're going to have an impact on how an individual surgeon works with drugs in their practice. Now, another drug we didn't hear about a moment ago, but is also quite effective, is a drug called setmelanotide. So setmelanotide is an agonist at the melanocortin-4 receptor. And those of you who've worked in obesity biology would know about the melanocortin-4 receptor. It's mutations in the coding region of the melanocortin-4 receptor are occurring about 1 in 340 patients, or 1 in 340 people, and mutations in the coding region are associated with a 17 kilogram increase in body weight. That makes it both the most prevalent and one of the most penetrative genetic disorders in humans. It's not rare at all, but the melanocortin-4 receptor is an important drug target because of that strong genetic evidence linking it to body weight. There is a drug approved that treats obesity by activating the melanocortin-4 receptor, setmelanotide. Now, it's only approved for very rare genetic forms of obesity, so mutations in the receptor don't count because if the receptor isn't working, putting an agonist to the receptor in isn't going to help it. It's used for mutations in processing the hormones that activate the receptor or for mutations in the pathway that the receptor lies in. So specifically mutations in leptin or leptin receptor or mutations in the processing of the peptide pro-opiomelanocortin, which makes an agonist at the melanocortin-4 receptor. And in patients very rare patients who have these mutations, setmelanotide causes striking weight loss, so 10, 15, 20 BMI units of weight loss, so very effective, but not really important for the kind of practice that you're working in. And there's been some data, I think, positive and negative around the effectiveness of bariatric surgery or metabolic surgery in patients with mutations in this pathway. So it's a newer drug, but probably not relevant to what we're talking about here. The reason it can't be widely used in other patients is because the melanocortin-4 receptor system, in addition to regulating body weight, also has quite profound effects on the cardiovascular system. And when the first drugs activating the system were described, I saw data in the Netherlands where after a first dose, the dog's blood pressure rose by 50 millimetres of mercury after the first injection. So quite profound hypertension is associated with them if the system's intact. So that's why the limitation is in patients who have mutations in this system. Now, Lee touched on some of the other drugs that are in development, and these are multi-receptor agonists. You can see here 4 of them listed. The first is an oral GLP-1 agonist. And this is quite exciting because the other drugs we're talking about here are all injectable therapies. An oral therapy has obviously a convenience factor associated with it, not just for the patient who takes it in terms of not needing an injection, but also for the ease of supply chain management. So an oral therapy means that we can deploy it much more widely and much more conveniently into populations that may not be willing or able to use an injectable therapy. And so this drug, orforglipron, has potential to really be quite dramatic in its impact. Now, the weight loss that's been seen with this drug at 15% is less than what we're talking about with some of the other drugs. But as I've designated with that plus symbol there, these trials are not standardised. These are not phase 3 trials we're talking about here. This is data from variable length phase 2 trials. And so they achieved this 15% standard, but they've achieved those weight losses at very different time points in the drug's pathway. And so as you've seen with some of the data in drug trial experiments, you have a rapid weight loss and then a decline towards a plateau over time. And sometimes that plateau takes a year to reach. So the weight loss you're seeing at 16 weeks or 24 weeks with some of these drugs is obviously not as low as it's going to go. We've seen data around, and I think I misspelled it, the GLP-1, GIPR and glucagon receptor agonist drug causing quite striking weight loss and again, impressive loss of liver fat. Another drug achieving similar kind of efficacy, and then CagriSema, which is a combination of semaglutide, the Novo Nordisk drug, and a new drug from their stable, congrulatide. So congrulatide is an agonist at the amylin receptor. Amylin is a pancreatic hormone and is the drug that, it's the target, or a mimic, is a drug called pramlintide that's used in the US for the treatment of brittle diabetes. But it's a 4 times a day injection, so it hasn't been very successful. Nonetheless, it looks like CagriSema is going to achieve probably the highest of this current generation of weight loss. In trials, in the phase 2 trials, it was hitting 16%, but people within the company talk about expecting it to exceed 28% placebo-adjusted weight loss at 1 year, setting a new benchmark, I think. And we haven't seen what some of the combinations that are proposed here can achieve out of that 1 year mark. But this is the only amylin combination that we've seen late phase clinical data for. And of course, 28% additional weight loss is an incredible amount of weight to lose. As I said earlier, these drugs are not just associated with pure weight loss, they've got quite profound benefits on health in other respects. It's pretty clear that the GLP-1 receptor agonists have a quite impressive anti-inflammatory effect, so leading to many benefits in tissues not conventionally associated with body fat, so decreases in inflammatory processes within blood vessels, having profound benefits on cardiovascular function, for example. Now, much as I love to listen to Lee, I'd actually have to disagree with him in terms of numbers of drugs in development. A recent pharma review said there's now 120 new obesity agents in early through to late phase clinical development. That's going to be a lot of new molecules coming to the market. And this also means that the manufacturing base is widely increasing. So for the longest time, it's been Eli Lilly and Novo Nordisk, and once we also had Sanofi playing in the space. But now there's many new companies entering the market. And there's been an explosion in the evaluation of new targets. We've talked about amylin. One of my favourite targets is the activin myostatin system. And the reason I like it is because it targets muscle. Now, muscle is critical in quality of life. Preserving muscle mass or gaining muscle mass, particularly as patients age, is really important for their overall function. In terms of obesity medication, though, muscle is important for energy expenditure because muscle, even when you're not working, causes significantly more energy, consumes significantly more energy than does adipose tissue. And we know that decreased energy expenditure can limit voluntary weight loss. So when patients try and lose weight through diet and exercise, one of the compensatory mechanisms that the brain executes is so it decreases energy expenditure, and that limits the kind of weight loss you can achieve, and indeed is probably responsible for the recidivism when people regain weight after a diet. Now, it's natural that lean mass is a part of weight loss, so whenever patients lose weight, they tend to lose about 1/5 of that weight as lean mass, and that's considered normal. There is a controversy at the moment about whether the GLP-1 receptor agonists have a disproportionate impact on lean mass and particularly on muscle. And there's data suggesting loss and data suggesting not disproportionate loss. I think the jury is still out on this. What is clear, though, is that GLP-1 receptor agonists do not cause a compensatory decrease in energy expenditure as a patient loses weight. So normally if a patient dieted and lost 10 kilograms, their energy expenditure would decrease significantly, and that would oppose further weight loss. When patients lose weight with a GLP-1 receptor agonist, whichever one we've tested so far, their energy expenditure does not decrease, and this is probably responsible for why the drugs are so effective. Now, again, we don't know whether the GLP-1 analogues are decreasing muscle mass, but they certainly don't seem to be decreasing energy expenditure. I'm still interested, though, in what we can do when we preserve muscle or if we can build muscle. Now, I'm an Australian. I grew up in the country here. I was really trying to find a way to show you photographs of unique Australian mammals as part of my presentation. And we saw a unicorn before, which I thought was beautifully slipped in. All I can show you here is this dingbat over here, this emu bobbing his head up and down. I can't find an obese Australian animal for you. What I can tell you is the dingo can lengthen its colon as nutritional environments get worse, so it can extract nutrition better, but no one wants to look at dingo colons. What I am going to show you is the impact of myostatin on biology. So myostatin is a protein that regulates muscle growth, and it regulates muscle by inhibiting muscle growth. So this is a whippet. And you know, whippets are lean, fast dogs. We used to use them for hunting rabbits. This whippet has plenty of myostatin. This whippet has no myostatin. This is Wendy the whippet, and you can see she looks nothing like a normal whippet. She is quite muscular. So myostatin is critical for inhibiting muscle growth. And without myostatin, muscles grow much bigger. You might have heard of Belgian blue cattle. They also lack myostatin. And you can see this is not any regular cow. This is an Arnold Schwarzenegger bull. Again, the lack of myostatin causes profound muscle growth. And so, not surprisingly, myostatin has been an active drug target for many years. We're yet to achieve success with it, but there's been a series of molecules recently described that have quite profound impacts, seemingly quite safe impacts, on the activin myostatin system. And recently, Eli Lilly paid about $3.5 billion for one of those companies, so there's a lot of activity in the space. All these targets I've listed here, amylin, activin myostatin, urocortin and apelin, appear to have capacity to build muscle, some more than others. Obviously, the activin myostatin is a profound muscle builder, whereas apelin, amylin and urocortin have modest capacity to build muscle, but all of them appear at least to be capable of preserving muscle in the face of weight loss. And so I find them really exciting targets. I think they're going to be exciting not just for their impact on body weight as a standalone pharmacotherapy, but for their contribution they can make to a comprehensive weight management package that includes metabolic surgery. It appears to me that 30% drug-induced weight loss is going to be possible in the very near future. And that means that we might see pharmacotherapy tried before surgery for many patients. I can imagine an environment in which regulators or insurance companies require a patient to have tried and failed pharmacotherapy, or tried pharmacotherapy to achieve more efficient pre-surgical weight loss as part of access to surgery. And I think for that reason, we need to be aware of what's happening and what's going to be happening in the future. Obviously, pharmacotherapy offers a new set of options. Effective pharmacotherapy offers a new set of options if surgical weight loss is insufficient. And if we think about the extremes of what can be achieved with surgery and with pharmacotherapy, we can imagine a world in which you can bring a patient to a BMI between 20 and 25 with combination therapy. As Lee said, we've got no understanding of why patients respond to any particular drug. We don't have a really excellent understanding of why every patient's obese. We have poor ways of stratifying patients into particular drug therapies. And so we're never going to know which combination works best yet. That's going to be down to individualised medicine and studying what works in the clinic. And of course, there's a question of cost. So while it's easy to say that in the short term pharmacotherapy is cheap, and we know the pricing now for these drugs in Australia, so low-dose semaglutide is $130 a private payer script per month, and high-dose semaglutide is $460 per month as a private payer script, coming out at about $5,500 a year. Whereas when we think about surgery, again, back of the envelope costs, we think about $25,000. There's still a pharmacoeconomics or a healthcare economics argument that needs to be played out here before we say that one is better than the other. And I don't think there really needs to be a case made for superiority here. It's about what can be best achieved in combination. Because what we really haven't paid a lot of attention to in a regulatory environment or in a prescription environment is what is weight maintenance and what's the best way to achieve it. And so we talk a lot about weight loss trajectories and weight loss at 1 year and 2 years, but that's only the beginning of the journey. We need to think about how we help patients keep weight off at 5, 10, 15 and 20 years. And the role that pharmacotherapy plays in that is going to be really challenging to explore. But I think we're approaching an era where, while it's complex, we are developing some really powerful new tools, and I'm really excited to see how those new tools play out in managing patients' health. So thank you for your attention.
All right, well, it's my absolute pleasure now to introduce our next speaker, Professor Phil Schauer. I've got to admit, I've been a bit of a fanboy of Phil for a long time, so I'm very excited to be able to introduce him. Phil's a former professor of surgery at the Cleveland Clinic and past president of the ASMBS. He's currently the professor of metabolic surgery research and the director of surgery at the Pennington Biomedical and in Louisiana. His academic and surgical prowess is well recognised, I'm sure, by everyone in the audience, and one of my favourite trials still remains the Stampede trial. So, Phil, I can't think of anyone better to address the question of what will bariatric interventions look like over the coming 10 to 20 years. Thank you, Phil.
Well, good morning, and Ahmed, Harry, Michael, thank you so much for the invitation, and it's certainly an honor to share this podium with these other distinguished speakers, Lee Kaplan, Michael Cowie, and Simon Koss. And we're all here to sort of pull out our crystal balls and opine about the future, the next generation. So I'll sort of throw my hat in, and I'll say that this is certainly an exciting era, and never in our 70-year history has the field been so dynamic and I think so promising. These are my disclosures. I don't believe any of these have any direct conflict with the presentation that I have for you. Now, when you begin to think about the future, it may be helpful to look at the past a bit. And I'll share with you sort of my take on what's happened in the last 70 years of our field, which really began in the 1950s. And it really is the history of not just bariatric surgery, but it is, in large part, the history of successful weight loss. And these are some of the major landmark papers that sort of hallmark the progress of our field up to the current time. You can kind of divide the eras, I think, into three distinct eras. The early intestinal bypass procedures, the GI bypass, which dominated the 50s and 60s. And they were supplanted by superior interventions, open gastric bypass, vertical banded gastroplasty, and the biliopancreatic diversion, which were operations intended to be safer, not necessarily more effective, safer. And then it was the mid to late 1990s when laparoscopy came about, where the operations became even yet safer with a less invasive approach. And that brings us up to the 2020s. And there may be some lessons learned from this incredible 70-year period. One is that those who embraced the change thrived and became very, very successful. Those who did not are gone and extinct. And so that's a major lesson, is embracing change and adapting. The second lesson is there really was no other sort of competing strategy of successful weight loss interventions during the 70-year period. As the two preceding speakers had pointed out, medical treatment was quite ineffective and to some extent insignificant, clinically insignificant in terms of its contribution to sustained weight loss. But now we're entering a new era, and I'd like to welcome all of you to the era of GLP-1 receptor agonists. And no matter what your current position on this, I would suggest that we all embrace this new era. It's not going away. We can look at it as competition. We can compare surgical interventions versus medical, and we can probably now make a good case that currently surgical therapy is still king. Or we can embrace this change, and as the theme of this whole conference is figure out how to integrate this new therapy with strengths that we have with metabolic and bariatric surgery. Now, the two previous speakers have done a phenomenal job about introducing these agents and their profound effect, particularly not only on the gut, but the brain at suppressing appetite. And many of these mechanisms may parallel and mimic what we're doing with surgery. And as Lee Kaplan very eloquently pointed out, surgery probably has a multitude of mechanisms that we're still trying to figure out, but some of them may clearly be on this GLP-1 receptor agonist level as well. Now we have this armamentarium of pharmacotherapy that is approaching efficacy of bariatric surgery. And again, it is, I think, which will dominate the 2020s, is how we, as a group, surgeons and other clinicians and scientists, figure out how to integrate and incorporate these therapies to receive yet an even greater impact, clinical impact, on obesity and metabolic disease with even greater safety. Now, these are the current procedures we have in 2024. These are the dominant operations in the United States. You could add to this list the single anastomosis gastric bypass as well. It's comparable to the gastric bypass. We have the duodenal switch and the SADI procedure. The gastric band appears to be maybe going toward extinction, perhaps. And we also have endoscopic procedures. And don't get me wrong, over the next decade, I think there's tremendous opportunity for surgeons to innovate with these procedures. We still have a lot to learn about how we can maximize the effect of a gastric bypass by extending various bowel lengths, but minimizing perhaps some of the long-term nutritional consequences. There's lots of opportunity with the endoscopic procedures to innovate there, to make them more effective. The ESG is a great example. And even new concepts using magnetic therapy. So there's plenty of opportunity to innovate and improve our surgical procedures. But I do think this next decade, the biggest impact is going to be how we integrate pharmacotherapy. Now, there's a lot of good things that we can say about metabolic surgery. The magnitude of the weight loss is still superior to the current pharmacotherapy agents, has been shown. And maybe even more important is the durability of the effect. And if you compare what we know so far in this early era of GLP-1 receptor agonists, semaglutide, tirzepatide, and even the more recent longer-term clinical or cardiovascular outcome trial with semaglutide, we don't even have 5-year data yet. So it remains to be seen, these agents, the durability over this time period. And this may be one huge strength of surgery. Once an intervention is created on the GI tract, we know, such as here in the SOS trial, that its effect is likely going to last decades, if not a lifetime. Whereas with a pharmaceutical agent, it's entirely dependent upon the frequent dosing. And we all know that there are many impediments to repeated dosing. The cost of the agent, the access to the agent, side effects, and so on that may prohibit individuals from repetitious usage of a pharmaceutical agent, whereas with a surgical intervention, it's generally there for life. So we can expect this will likely be a strength of metabolic surgery for many, many years to come compared to pharmacotherapy. We also have some wonderful data accumulated over the years showing that this magnitude of weight loss combined with the durability equates to major improvements in all of these comorbidities, including cardiovascular endpoints, heart attack, stroke, death, and even reducing cancer. So achieving and maintaining weight loss, we know is very hard. We've seen it with surgery. We quite haven't seen it yet with a pharmaceutical agent, but yet we have to admit, very, very promising for those agents as well. And not only do we have studies like the SOS, but we have more modern studies, quite a number, gastric bypass, 10-year data, 30% weight loss, sleeve gastrectomy in the 20% or above weight loss at 10 years. And there's nothing in the pharmaceutical realm that goes out to 10 years so far. So these are very, very promising strengths of surgery. So in fact, at least currently, surgery has a lot of strengths, superior to medical therapy in virtually all of these categories currently. Magnitude, durability. We know they're effective even in high BMI patients. The drugs haven't been tested in that category, the most refractory obesity. We can even reduce dependency on medications, which is a positive. Comorbidity improvement, cardiovascular benefit, a reduction in NASH fibrosis or MASH fibrosis, cancer reduction, and even cost effectiveness. So these are the current superiorities. But I think the real question is, how can GLP-1 agents improve surgical outcomes over the next decade or so. So let's talk about some potential areas. And I wish I had a bit more time to delve into these a bit more, but let's just talk firstly about safety. Now, we've come a long way in 70 years in dramatically reducing complications of surgery. And here's a recent, very nice review of our MBSA QUIP database. And just over the last 5 years, up to 2019, we're continuing to make major improvements in reducing all-cause mortality. Metabolic surgery, it's even less lethal than cholecystectomy. 0.018% mortality. That's pretty impressive. We're getting our patients out of the hospital quicker. We're reducing readmissions. Complications like pneumonias and cardiovascular complications continue to drop. Bleeding is dropping. Infections are dropping. So we're continuing to make improvement. However, there's still room for improvement, especially in our higher risk patients, patients at that higher BMI range, or those patients with very significant comorbid conditions, heart failure, for example, cirrhosis. And many of us are shying away from those individuals. Many of them are never getting surgery. And particularly this high BMI group, there's some recent evidence suggesting that, at least in the US, the subgroup of patients with obesity that's growing at the highest relative rate is this high BMI group, BMI of 50, certainly 60 and 70. And if you look at our data tracking, we're not doing more of those patients. They're not getting surgery, perhaps because, at least in part, because of the operative risk. Well, this is an opportunity to embrace medical therapy, and just give you one example that we experienced at our center at Pennington is using these agents preoperatively. And I know many of you are also experimenting with this approach as well. And it's not anything new. What's new is, in the past, we were lucky if we get 3 or 4% weight loss prior to surgery. But now we have agents, like in this study, patients with a BMI of 70, when you combine, and in blue is a group that's getting multimodal, or getting GLP-1 agonists and perhaps other anti-obesity agents, versus green is just a GLP-1 alone, and in red are those patients, that group that just got essentially lifestyle intervention without drugs. You can see doubling of the effect when you combine agents and achieving a 13% weight loss prior to surgery. We all know that equates to significant improvement in the operative risk. There's nothing more therapeutic than weight loss in terms of optimizing patients prior to surgery. So I think this is one area that we should clearly embrace, and clearly more studies are needed in this arena. But I think the real promising area is in efficacy, and specifically the potential power of combining the two most effective treatments for metabolic disease: pharmacotherapy and metabolic surgery. And we can look back at some recent studies that are going to give us, I think, a glimpse of what we might be able to expect when we combine surgery with these more effective GLP-1 agents. So let's look at these randomized controlled trials that you all are familiar with, evaluating the effect of metabolic surgery compared to medical therapy on patients with obesity and type 2 diabetes. Now, to be clear, these are not just surgery versus medical. These are really medical alone versus surgery plus medications. In all these studies, medications are not eliminated. And why would you? Why would you not want to include medications? Now, when you compare these strategies head to head, always surgery plus medication beats medication alone. Whether your primary endpoint is an A1C target or weight loss, we have near unanimous level 1 evidence pointing to that point. Now, what about durability? And I want to share with you accumulation of 4 of these studies in the ARMS trial, looking at the effect long term, because the durability of the treatment is key in a chronic relapsing progressive disease such as obesity. So 4 trials got together and accumulated their data and got funding to follow their patients beyond their initial trial period. So Stampede was a 5-year study. Crossroads was just 1 year. Crossroads is a group at University of Washington. The SLIM trial is a group at Beth Israel and Joslin in Boston. They had 3-year data. And then the group in Pittsburgh, the Triabetes study, they had 5-year data as well. So these 4 groups got together and brought their randomized controlled trial subjects together and began following the patients with a uniform protocol over the next decade or so. So that has culminated into the largest study so far of collated randomized data comparing metabolic surgery with medical treatment. But again, to be clear, it's metabolic surgery plus medications versus medications alone. Let me just share with you a little bit about the outcomes, because I think it's going to inform our future to a large extent. So again, the trial design included about 350 patients, 4 different sites, who were randomized to either an intensive medical strategy, included lifestyle plus medical treatment, versus metabolic surgery, the 3 common operations, bypass, sleeve, and gastric band, and of course, medical treatment as well. Now, at the beginning of these studies, back in the 2005, 2010 range, there weren't very many effective anti-obesity medications, but over time, many were added, particularly GLP-1s, as they became available. So let me share with you the primary endpoint, shown right here. This is a diabetes study, so the A1C was the primary endpoint. The combined surgical group is in blue. The medical lifestyle is in red. And you can see the 12-year endpoint. And you can see the superiority of surgery, banding, sleeve gastrectomy, and gastric bypass, compared to medical management alone. A couple important things to point out: about 25% of the patients in the medical group, so 1/4, crossed over to surgery. This is an intent to treat analysis, so we counted them as the medical group. And also, both groups were getting medical therapy, and toward the end, approaching half of the patients were on a GLP-1, and as the more potent, agents such as semaglutide became available, they were added as well. And the surgical group, some of the patients were on GLP-1 agents as well, 15%. So you can see here that the effect of surgery and even modestly combining medications was by far superior to medications alone in terms of glycemic control. You can look at other endpoints. Remission. Remission is interesting, and the way remission is defined now is the absence of medication. And while surgery is very effective, at least initially, at producing an effect that doesn't require any anti-diabetes medications, that effect does appear to wane over time. In such case, why not add more effective agents to improve glycemic control over time? And when you look at the medication usage at baseline in both groups were heavily using oral and GLP-1 agents, and even insulin at the beginning. But one advantage of surgery is that while medications are still required in many cases, a decrease in dependency on some medications is beneficial. But yet, surgery plus medication still was able to achieve a superior result than medications alone. This was true at 7 years and at 12 years as well. Now, what about weight loss? Similar. Blue again is a combined banding, sleeve gastrectomy, gastric bypass. Again, note the 25% crossover rate. Surgery plus medications superior to medications alone. Now imagine in the surgical group if we're able to now, going forward, add these more potent GLP-1 agents. Imagine what that synergy might be. And we've seen other studies now with long-term follow-up, randomized controlled trial. I'll just point out the Mingroni-Rubino study showed very similar findings. Medication alone, which is the control group, versus surgery plus medication was far superior than medication alone, and again, dealing with far inferior medications. And just think what will happen when we combine surgery with these more potent pharmacologic agents. Now, perhaps more important than these surrogate markers are these hard clinical outcomes. And we've been able to accumulate over the last decade or so quite a large number, mostly observational data, at the effect of metabolic surgery and medications compared to medical treatment alone. And it's pretty amazing the impact of surgery, what it brings to the table. And this huge meta-analysis from European Heart Journal, this was done by cardiologists, not surgeons. You can see an 18% reduction in atrial fibrillation, typically when you add surgery. 50% reduction when you add surgery to standard medical therapy. 42% reduction in myocardial infarction. 36% reduction in stroke. So the potential of even adding more effective agents to surgery, I think, is quite alarming. Now, here's an interesting study which is beginning to look at surgery versus the new GLP-1 receptor agonists. This is looking at CKD progression done at Cleveland Clinic by Aaliyah Minion and colleagues, looking at an 8-year period. Patients who had CKD, chronic kidney disease, stage 2 or 3, were compared with those that were treated with standard care, medical management versus surgery. When you add surgery to medical management, you get a very significant reduction in progression of CKD, which is critically important. Now, just imagine what might happen if we add to surgery these newer GLP-1 agents. And in addition, perhaps the most important long-term endpoint is actually mortality. Surgery versus usual care can achieve nearly a 50% reduction in mortality. But what about the potential synergy if we add surgery again with these newer, much more potent GLP-1 agents? And we can get a glimpse of what we might want to expect when we look at the SELECT cardiovascular outcome trial that you all are familiar with, that was published this past fall. This is the first time in history that a pharmacological agent intended for weight loss, not intended for diabetes control, showed a cardiovascular benefit, a MACE benefit, a composite of cardiovascular death, non-fatal MI, non-fatal stroke, and we see an actually 20% reduction. Now imagine adding that on top of a surgical platform where we're already seeing a 50% reduction in mortality. Imagine the potential synergy. So as I come to a conclusion, I think we're entering an extremely exciting era. And I think the potential is really, really amazing. And I'm going to share with you a sort of hypothetical scorecard of what it might be when medical treatment alone, based on some of the current agents, versus metabolic surgery plus the current agents. And you can see it, all these major categories, it's very likely when we combine them, we're going to get either an additive or a synergistic effect with them. Whether it's short-term weight loss, long-term weight loss, the effect on more refractory obesity such as high BMI. Combining these agents preoperatively may help us reduce complications of surgery and adverse events. perhaps getting boosts in quality of life, and then more effective treatment in some of these very challenging areas, steatohepatitis, cancer reduction, MACE events, and so forth. So I do think this is an opportunity for us to embrace the future, and those of us who change and adapt to this are going to be the ones who are going to succeed, and those who are reluctant may be the ones that will not succeed. So welcome to the new era of GLP-1 receptor agonists. They're going to dominate the next decade or so, and it's us to embrace the change and learn how to integrate them into our treatment strategies. Thank you very much.
Phil, thanks for sharing. It's a great talk as always. Our final speaker for this morning's session is going to take us into the future. Simon Koss is a medical graduate from University of New South Wales. He moved quickly out of his chosen career path in clinical care medicine to move into science, AI and technology, and he moved overseas and became Microsoft's World Chief Medical Officer before moving back to New South Wales for family reasons, where he's Australia's Microsoft Chief Medical Officer, and he's done a lot of work and a lot of talking about integrating new technologies and AI into health. Thank you, Simon.
Thank you so much, Michael. And Phil, thank you for giving me the perfect segue into the new era of change. We're going to talk a little bit about artificial intelligence and what it's doing to the whole discipline of healthcare at the moment. But before I do, I just wanted to do a quick acknowledgement of country. We had that fantastic welcome to country. I haven't seen anything like that before, but I wanted to pay my respects to the traditional owners of the land and thank them for their ongoing custodianship, and extend those respects to any Aboriginal elders here today. So for context, and let's make disclosures fun, I am an emergency doctor by background, but I got into technology before it was cool, thinking that if we could just put electronic medical records in, we'd stop some of the errors that I saw in my critical care pathways, emergency, ICU, anaesthetics. That took me. I realised that we need more than electronic medical records, so I moved across to Microsoft. And now I'm the ANZ Chief Medical Officer. That's Australia, New Zealand, not the Bank, Harry. And I do some work in the startup community, lecturing, advising, that sort of stuff. And I do hold a board role, none of which really is a disclosure that's relevant for today's presentation, but it gives you an idea of where I'm coming from. I wanted to start here in the amazing digitally native consumer homes that we have at the moment. That's certainly not my home. We've got a new puppy and I've got 3 kids. Our place is a bit of a mess at the moment. But I think it's amazing that in today's society we can have technology transparently and seamlessly in the background, collecting information and serving it back up to us in actionable and useful ways. If we're able to do that in the consumer's home, we've transcended a couple of the limitations that have held us back, and this is aspirationally where we need to get to in healthcare. First is the user interface. We've made technology so simple to use that no one needs to read a manual anymore, it just works. And if it doesn't, that's poor design. And the second is cost. If we're able to get it into the consumer's home, generally by making the computing happen in these huge cloud data centres, piping that capability down to relatively small devices, we've solved the cost equation, user experience and cost. That's the consumer home. And then if there was one silver lining out of the COVID period, it's the fact that we have learnt as organisations how to get work done with virtual teaming technologies. life went on. But for those of us working in healthcare, sometimes it feels like the digital revolution has left us behind. And it's not just care teams that struggle with the technology that we have in healthcare. It's everyone from the consumer, the patients, who are used to being empowered in other industries with tools that transparently help them understand what they can do, and they're empowered to self-manage, through to clinicians who have more technology and data than ever before, but it's really hard to put your hands on the right information at the right time. And then for those people who are running health systems, it's impossible to do that unless you've got real-time and up-to-date, accurate data. So I said today's talk would be about artificial intelligence. Let's jump right into it, because this is what I think we'll look back on as the advent of the era of AI, and it's affecting healthcare just like it is every other industry. The first point to note is there's a lot of hype about it at the moment, but let's all remember that artificial intelligence has been here for decades. When I was practicing, even as an intern, ECGs were rolling off the carts with automated interpretations. And I remember what the specialists would say at the time, particularly the cardiologists. They'd say, don't read the interpretation, look at the trace, make your own judgment. And they were right. The algorithms back then were imperfect, and you did need to use your clinical acumen. But one of the things that they were not saying at the time was that they got paid to report ECGs. Now, what were they thinking of? They were thinking that, is artificial intelligence going to come take my job? Will it replace me? I guess if we look back those 25 years to now, we've got more cardiologists than ever before, and arguably they're doing the high-value work of engaging with patients rather than sitting in their rooms reporting ECGs, although that certainly still does happen. For the longest period, I thought this is what artificial intelligence in healthcare was going to be. It would be that diagnostic capability. How do you take data and then use computational algorithms to figure out, is that a pneumonia? What's going on with my diabetic retinopathy? Interpreting skin lesions and pathology. I thought that was the role of artificial intelligence. But something very dramatic happened. I woke up to it in December of 2022 when ChatGPT was released by OpenAI, and generative AI is a game changer. The first technologies that we talked about earlier, they're what we call narrow artificial intelligence. Generative AI is probably the first glimpse of what we talk about as artificial general intelligence. These are technologies that come pre-trained. It's pretty extraordinary because what it means is you take a technology, unlike machine learning where you use a whole bunch of data, you have a hypothesis, you supervise the learning and you train it to do a very specific task. Generative AI comes pre-trained out of the box, and for that reason it rapidly became a global phenomenon, the fastest consumer service to hit 100 million users. It did that in under 2 months because you could send it novel use cases and it would come back with surprising results. I remember helping one of my kids with his homework assignment. It was the influences of immigrant influences in shogunate Japan, and ChatGPT was able to break the back of that super quickly, and then we could spend our time actually structuring once we had the structure, figure out how we were going to answer that question effectively and do a bit more research to make it our own novel work. Kids wrote me a poem for Father's Day, arguably not their work, but it was better than any of the other poems they'd written before. It's gotten to the point where it's multimodal now. You could take a picture of what's in your fridge and ask it what you might be able to make for dinner. These are novel use cases, which is extraordinary. There are lots of technical definitions. I think this cartoon is one of the better ones. I'm going to show you examples of both of these, how we might be able to take relatively imperfect documentation and turn it into more prosaic narrative and then use it for other use cases, or then summarise large sets of data and turn it into key insights. So for those people who will tell you what the future looks like in artificial intelligence, we really don't know. This is just getting started, and I'm leaning in with a spirit of curious experimentation. I do think that anytime you introduce technology, it has great potential, both for good and bad. It's an amplifier. I've been leaning in looking at specific scenarios. I started with clinical documentation, and that's rapidly become one of the hottest topics in generative AI in medicine, this concept of ambient clinical scribes. But going from documentation to checking for errors, producing secondary documents, even things like improving billing and structuring unstructured data, using it for research as well. Just before I show you some of what I discovered, I'm going to make a few qualifying points. The first is autopilot versus co-pilot. This technology actually needs a human in the loop. That's really good news for all of us sitting here today. The reason we need a human in the loop is machines are fallible, someone needs to be accountable, there needs to be oversight, like I said, potential for good and bad. I do think it's going to change how we practice. We talk about the science and the art of medicine. I think the science of medicine increasingly will be addressed by technology. They're great at moving rapidly through high volumes of data, looking for where the errors are, being responsive, and then doing predictive analytics across large cohorts. What does that mean for humans? I think the art of medicine becomes even more important. Who's going to break bad news to the patient, develop that doctor-patient bond, that empathy? Who's going to be accountable when things do inevitably go wrong? And humans have this wonderful ability to be creative and think outside of the box. I'm going to show you some experiments that I did using a large language model that I've got access to. It's an enterprise generative service. There's a difference between the consumer services that we've probably all played around with and the enterprise ones. So the consumer ones, and I picked on ChatGPT, but there's plenty of other ones, they're generally free services that run outside of Australia. That's important if you're sending data to the model, which is what you do with one of these free services. And they actually use that data to continue to train the model, which is fantastic because they learn, they grow, they develop over time. It's not great if you send them sensitive information and that gets incorporated into a model that is then discoverable later. And they're often black box AI. You don't really know how it got to the answer, even if the answer looks right. That's quite different to an enterprise service, which generally uses the more powerful models. It does run, the one I use runs here in Australia, and instead of sending your data to the model, you bring the model to your data, and you can unpick that model to see how it got to the answer. So this whole concept of explainability. So I'm going to show you this. This is the note that I had to work with. I went to one of my cardiology mates, and he dictates his letters. So he writes quick notes to himself in his cryptic cardiology shorthand, and I can read some of that, but some of it is actually cardiology specific. I needed him to explain to me what HREF meant, high residual ejection fraction, and then take a look at the last sentence, pulmonary hypertension clinic, because why not? He's written this note as an aid memoir. No one's ever meant to see it, although lots of people now have. I wanted to take this documentation and plug it into this model. So what we've got up the top is a prompt. This is where you tell it what to do. And I grabbed that note. What I've asked it to do is You're a medical student, you're a medical assistant, users will paste in a string of text and you'll respond by converting the medical shorthand to a clinical note, expanding on abbreviations. And it's going to spit out down below a clinical note, and it actually reads really well. Interestingly enough, have a look at the last thing. Refer them to the pulmonary hypertension clinic for further evaluation. It's even tidying up some of that laziness. I showed it to Dr. Michael Franco when he was over at Monash, and he said, I like the other one better because it was structured. Can you structure it? So we did that. We altered the prompt to make it a structured note. And now you can see that there are clear headings. I've taken the note that it produced, and I'm going to use this to do secondary activities. So users will paste in a string of text. You'll respond by seeing if the doctor missed anything. So if the first question was around, could you take this note and make it pretty? This is actually, can you help me tidy up? Can you help me by tracking for errors? The doctor did a thorough assessment of the patient and documented his findings well. However, we could ask the patient about the frequency, severity and precipitating factors of his chest pain, perform a 6-minute walk test, a whole bunch of things there, which is interesting. This is not a medically trained model. This is right out of the box. Users will paste in a clinical note and you'll respond by suggesting how the patient might be feeling. Help me with my bedside manner. Patient might be feeling relieved that his condition's stable, anxious about his risk, frustrated, motivated, curious. Now we said that the computers won't help you be a more empathetic practitioner, but we've got glimpses of that too. Let's write a referral letter. This happens all the time. We do one form of documentation, now we need to do another one. Haven't told it where to send the referral letter, but Dear Pulmonary Hypertension Clinic, we're writing to refer John Brown, 73-year-old male, who was experiencing symptoms. We'd appreciate your assessment and management of his suspected pulmonary hypertension. Thanks for your time and attention. We could even write a note for the patient as well to explain the condition. You have a history of heart attack, kidney disease, stroke and irregular heartbeat. You came to the clinic because you had chest pain. We could do this in real time. Beyond helping the clinician with their documentation and the patient understanding their condition, we could also fast track some of the back office stuff that typically happens in medicine. So in this instance, I've asked it to mark up the SNOMED CT terms. This is structuring unstructured documentation and turning it into something that you could use for medical coding and case mix. I could ask it for MBS billing codes and potential billable procedures. So let's see what it does with that. Interestingly enough, over on the right-hand side is a temperature setting, and it's suggested a 110 for that, with possible electrocardiogram, blood pressure measurement, and referral to the pulmonary hypertension clinic. I could even turn it into a fire message, and this is how you get systems to talk between each other. Okay, just looking at the time, I'm going to finish it up there. So there's a fire message that would then allow System A to talk to System B. So just in conclusion, I wanted to let you know that the era of AI is here, unless you haven't noticed it already. We're figuring out the use cases. There's a lot of exciting potential for these technologies, and you'll be seeing more of it that will influence your practice over time and the other clinical disciplines that you're in. Thank you very much.